My name's Dr. Jenny Hoy. I'm the Director of HIV Service at the Alfred Hospital in Melbourne, and today I'm going to be talking to you about the early toxicities associated with antiretroviral therapy. Here are my disclosures. My institution is reimbursed for my time on advisory boards for Gilead Sciences, Vive Healthcare, and in the distant past MSD. We're going to go through a sort of a practical guide to assessing common toxicities in patients receiving first-line antiretroviral therapy, both clinical and laboratory toxicity. We're going to talk about renal toxicity, rash, which is much less common today, neuropsychiatric toxicities, weight gain and the current concerns about weight gain, liver toxicity and gastrointestinal toxicity. Now, these are some of the regimens that have been discussed as potential first-line therapy. I do have to say that we are not using efavirenz, nevirapine as first-line therapy. Lopinavir, ritonavir, you would only be considering in pregnancy if other regimens were not suitable. And the other addition is that dolutegravir is available as a dual regimen with 3-TC and without the abacavir. So we'll start with a change in the estimated glomerular filtration rate. Now, this slide shows all of the potential causes of a change in eGFR. If we go to the right of the slide with symptomatic HIV infection and HIV-associated nephropathy, which we rarely see in Australia, this is a renal disease seen predominantly in people of colour, and we've only had a handful of cases in Australia. More commonly is the use of concurrent nephrotoxic drugs, and these can be purchased over the counter so that we may not be aware that our patients are taking these. Concurrent infection and underlying renal disease are very important causes of change in the eGFR, as is antiretroviral therapy. Just a reminder of the stages of chronic kidney disease as described in Australia. Stage 1 kidney disease is normal kidney function but with some kidney damage. What we are most concerned about is stage 3A to stage 5, where we need to start to consider effects of antiretrovirals and whether we need to change the dose of antiretrovirals. Now, the spectrum of the acute issue of renal function changes is all the way from early acute renal failure, which is very, very uncommon, to transient changes in renal function, to more long-term issues, which we will concentrate on in the late toxicity session. So underneath the progressive renal function there are minor changes in renal function with or without proteinuria, and then progressing to more progressive renal function. So how do we approach a patient who's had a change in their eGFR, who has also recently started antiretroviral therapy? Now, we do need to consider how immune deficient the patient is because of some of the kidney disease associated with HIV. And as I said, this is very uncommon in Australia, and also the treatment for HIV-associated nephropathy is actually institution of antiretroviral therapy. We really need to consider whether the individual has started non-steroidal anti-inflammatory drugs or other nephrotoxins or protein supplements, which can alter the measurement of renal function. The trend is also important. If there is an acute, significant drop that continues after the first 2 to 4 weeks, rapid action is really required. And then we need to look at what antiretrovirals the patient is taking, and also whether there are physiological changes versus pathological changes. And the physiological changes we're going to talk about in the next couple of slides, as well as the pathological changes. The most common causes of pathological change in renal function are the use of tenofovir disoproxil fumarate, which is rarely used as an initial regimen today, as well as atazanavir. The pathological changes to tenofovir disoproxil fumarate can actually cause early acute renal failure with acute tubular necrosis or interstitial nephritis. We always recommend checking renal function at 2 to 4 weeks after initiating therapy. Now, the majority of regimens that we use today use the other formulation of tenofovir, the bone and kidney friendly form, which is tenofovir alafenamide. And there is far less renal toxicity with TAF or tenofovir alafenamide, but there have been reports of some renal toxicity in a handful of cases, so we still need to monitor the renal function. With atazanavir, it causes crystals in the kidneys, which form stones and nephrolithiasis, with the complication of obstructive nephrolithiasis with ureteric obstruction, but also parts of the kidney may become obstructed, and with subsequent renal impairment. Renal impairment can also occur due to interstitial nephritis with atazanavir. So these are the two drugs that are mainly the culprits in causes of significant pathological kidney disease. If we move on to the physiological effects on the kidney, and this is really an effect on the measures of kidney function rather than real change in kidney function. You'll see there that cobicistat, dolutegravir and rilpivirine are the most common causes of this physiological change. Bictegravir also causes this, as does, to a more minor effect, baby dose ritonavir. And what happens, and you'll see this on the next slide, is that we see an increase in creatinine and a decrease in measures of eGFR due to inhibition of some tubular enzymes in the kidney. The magnitude of these changes is small. For the increase in creatinine, it's about 9 to 10 micromolar, and for the eGFR, it's between 10 to 14 mils per minute. It occurs immediately, so that you get a reduction by 2 weeks with consistent levels following that. Here is how these drugs affect the cation transport in the tubules. So there's an OCT2 enzyme and a MATE1 enzyme on both sides of the tubule, which are inhibited, as you can see there, by rilpivirine, dolutegravir and bictegravir for the OCT2. For the MATE1, you can see it's cobicistat, ritonavir, but you can see some other drugs as well, cimetidine and trimethoprim, also cause a similar change. Now, there are later effects of tenofovir disoproxil fumarate, and that is Fanconi syndrome. This is a renal tubular acidosis syndrome. One gets glycosuria with a normal blood glucose. You get phosphate wasting through the tubule, so you have phosphaturia, but with hypophosphatemia, low phosphate in the blood. You can get low potassium levels in the blood, and you can get a mild acidosis and chronic kidney disease without Fanconi syndrome. So when you're using tenofovir, and in particular tenofovir disoproxil fumarate, it is really important to monitor and screen the EGFR and protein in the urine. So we recommend that this is done at 2 to 4 weeks after initiation. Now, as you all are aware, tenofovir disoproxil fumarate has been replaced by generic formulations of tenofovir, which aren't disoproxil fumarate. There are other forms of tenofovir. We have no data on whether these formulations have similar rates of renal toxicity as the disoproxil fumarate formulation, but we presume that they are the same and not as severe as the TAF. It's important to remember that there are recommendations for dosing modification at different levels of creatinine clearance. Now, when we use an EGFR, it may be different to the actual GFR. So it's important to ask your pharmacist to help you to calculate the actual creatinine clearance to modify doses of these drugs. You can see that at a creatinine clearance of less than 50 mils per minute, or those on hemodialysis, we need to modify the doses of lamivudine and emtricitabine. Tenofovir disoproxil fumarate requires modification at less than 50 mils per minute also, whereas TAF you can use down to 30 mils per minute. You can actually use TAF with hemodialysis as well. And with the cobicistat boosted elvitegravir, you can't use it below 70 mils per minute. If you're using the tenofovir disoproxil fumarate formulation, this Stribild, elvitegravir, cobicistat, TDF, and emtricitabine has now been removed from the market in Australia, so there will be virtually no patients on that. Whereas the TAF form of elvitegravir, cobicistat is in current use as Genvoya. And it's always important that you check current guidelines for use of antiretrovirals at different levels of the EGFR. So how do we assess and manage someone that has had a change in their EGFR? As I said, it's important to think about the physiological versus the pathological change. With the physiological change, the change is immediate on initiation of antiretroviral therapy, and then it should be a change set point, so a reduction in EGFR, which then remains stable. If there is a continuing fall in EGFR after that initiation, then other causes of kidney disease need to be considered. So we need to look at the actual glomerular filtration rate and measure that using an MDRD. Our laboratories don't have the patient's weight or race, so the MDRD is difficult for them to report, so they report the Cockcroft-Gault EGFR. We need to consider pre-existing renal issues, and particularly as our patients are getting older, there will be other existing renal issues. They may be due to co-infections, due to hepatitis B or hepatitis C, which can cause kidney disease, and also, very importantly, concurrent nephrotoxic drugs. We need to exclude obstruction with a renal ultrasound, looking for stones, obstructive nephropathy. The ultrasound is also important to exclude renal artery stenosis as a cause of hypertension and kidney disease. Hypertension and without renal artery stenosis and diabetes are important causes of kidney disease in our population. We need to look for proteinuria, for active sediments, for red blood cells, white blood cells in the urine. We need to look for glycosuria to rule out both diabetes with an elevated blood glucose or Fanconi's with a normal blood glucose. You may need to refer to a renal physician for consideration of a renal biopsy to diagnose glomerulonephritis if there is an active sediment in the urine. And then you need to think about, could the antiretroviral therapy be implicated in this chronic or acute kidney disease? And should we reduce the dose of the antiretroviral therapy, or should we switch the antiretroviral therapy? And this is something that would be ideally discussed with your mentor as well as a nephrologist. Now we'll move on to rash. Rash is very uncommon today on initiation of antiretroviral therapy. And if it does occur, it's usually transient, minor, and self-limiting. It used to be much more common than it is today. 20 years ago, we did see more severe rashes, Stevens-Johnson syndrome, which is rare, very rare today. And it was associated with varying degrees of hepatotoxicity if you did get more severe rashes. So if you do have someone presenting with a rash with their first-line regimen, it's very important to assess the severity of the rash, because there is a spectrum, as I said, from isolated mild rash to Stevens-Johnson syndrome. And you need to decide whether this patient needs to be referred to a hospital infectious diseases unit urgently. And one can get some advice from your mentor or from the hospital unit whether that individual needs to be referred immediately. And the way you might do that is you look at systemic symptoms and signs as well as the rash, whether the individual has fever and mucous membrane involvement. Now, we all know to look in the mouth, but sometimes we forget the eyes and the genitalia that can be involved with severe rashes. And there's multi-system involvement, so you might look at liver function and renal function as well. If there is Stevens-Johnson syndrome, which is a constellation of fever, rash, which starts off just as erythema, moves to macules, papules, and then you get necrotic skin and sloughing. It's like having burns, and it is managed like one has burns. Mucous membrane involvement occurs in over 90% of patients with Stevens-Johnson syndrome, and organ involvement is very, very common. These individuals need urgent management. You need to do a full blood count, renal function, liver function, and you stop all drugs immediately and refer the patient immediately to the hospital. If you suspect Stevens-Johnson syndrome, it should be immediate. This is a photo of someone with Stevens-Johnson syndrome. It was due to nevirapine. And this person was managed in the burns unit at the Alfred Hospital. And you can see some of the sloughing from her face. You can see the swollen lips and mucous membrane involvement of the lips. Now, this was most common with nevirapine, which is very rarely initiated today. You may find many patients still on nevirapine. If they were able to tolerate the drug in the first couple of months, it's a very well-tolerated antiretroviral drug. Efavirenz certainly can cause rashes and Stevens-Johnson syndrome. Rilpivirine can cause rashes, so you may see it today with rilpivirine. Certainly, it's much rarer with the nucleoside reverse transcriptase inhibitors. Darunavir causes rash, as does fosamprenavir in about 15% of patients, and raltegravir rarely causes a rash. Now, before we had the ability to assess HLA-B5701 status, and when we used quite a lot of abacavir hypersensitivity is associated with rash. It would occur between 11 and 21 days after initiation, but always within 6 weeks of initiation. And there would be a mild rash, but also constitutional symptoms and organ involvement. We did have some mortality associated with re-challenge with abacavir. So it's very important that all individuals for whom you are considering the use of abacavir have that HLA-B5701 test. So it's not only antiretrovirals that can cause rash. I think it's very important to remember that Bactrim, sulfadiazine, some of the sulfur drugs, dapsone, used for prophylaxis and for treatment of opportunistic infections commonly cause rash in people living with HIV. And the incidence of rash and these reactions is actually more common in people with HIV compared to the general population. But it's also important to rule out syphilis. We have a syphilis epidemic occurring at the moment. There are other skin conditions that can cause rashes, and of course immune reconstitution syndrome can also exacerbate underlying rash. What is immune reconstitution inflammatory syndrome? Well, it's an aberrant inflammatory response to a known or subclinical infection that's associated with recent commencement of antiretroviral therapy in someone who is immunocompromised. So what we see is flares of common infections. For example, if someone has shingles, there will be a flare of the skin around the base of the vesicles. HSV, exactly the same, molluscum contagiosum. We also see flares of folliculitis in individuals that commence antiretroviral therapy when immunocompromised. Fungal infections that have cutaneous manifestations such as Cryptococcus and Talaromyces marneffii. These will be discussed later in Module 7, however. We'll move on to neuropsychiatric presentations, and I think the first thing to be cognizant of is actually anxiety, depression and mania are very common in people living with HIV without antiretroviral therapy. But adding some antiretroviral drugs on top of these manifestations can exacerbate them and also cause neuropsychiatric effects in people without these psychiatric symptoms. Efavirenz is the most common cause of neuropsychiatric effects, and it usually occurs on initiation and is readily apparent within 2 to 4 weeks of starting the drug. The most common complaints are vivid or technicolor dreams, Some people have insomnia, others have drowsiness, some have dizziness. People complain of being spaced out or just feeling odd. Others have a low mood and are depressed. Some people feel like they're going mad. The ephedrine's symptoms often abate within a few weeks of starting the medication, and so these symptoms may completely resolve if the individual can tolerate them for those first 4 weeks. But then there are symptoms that do continue for the long term, and because patients just become accustomed to them, they don't complain of them, but it may have impact on their life, on their work relationships, on their personal relationships. And the way we manage it is to switch. We have a lot of alternatives to ephedrines today, but many patients are reluctant to switch from ephedrines or from their atripla. This is just a reminder that this was a meta-analysis done of multiple studies performed in the ACTG in the United States, which shows that there is a significant hazard of suicidality for people taking ephedrine. So we must listen to our patients. If they are feeling suicidal, we should absolutely take them off the ephedrines. And it's also interesting, I have been referred patients from overseas who've been on ephedrines and won't change, but they've also been on medication for insomnia, and I've changed them off the ephedrines and they no longer need their sleeping tablets. So people have tolerated this without realising it's having a significant effect. So how do we evaluate neuropsychiatric effects? Remembering that they're more common, but we also must think about recreational drugs, the impact of alcohol, excess alcohol and psychosocial factors in the lives of people living with HIV. And there's also the possibility of cognitive impairment in those who have more advanced disease. People on older drugs with known neuropsych effects, it's important to switch if there are any symptoms. Weight gain is an issue of concern for 2020. And with a number of cohort studies and now with a couple of randomised controlled trials, it appears that both tenofovir alafenamide and the integrase inhibitors are associated with greater weight gain compared to abacavir or tenofovir disoproxil fumarate as the backbone, or NNRTIs or PIs in the antiretroviral regimen. It's also clear that women, people of colour, including Hispanic race, are affected disproportionately compared to Caucasian men, with a greater magnitude of weight gain occurring in people who are antiretroviral naive versus those that switch, but weight gain does occur in those that switch also. The pathogenesis, the clinical significance, and also the reversibility is unclear at this point in time, although there's a hint that there might be greater metabolic syndrome and diabetes in those with significant weight gain. This is data from a randomised controlled trial. This is in men who were randomised to one of three regimens. You can see that on the graph to the far left, that this is the men who received TAF and dolutegravir. In the middle graph, it's tenofovir disoproxil fumarate and dolutegravir, and in the far right, it's tenofovir disoproxil fumarate and ephedrines. The red is the proportion of men over time that have greater than 20% weight gain. So I think we need to be very clear that it's very small proportion that are experiencing very significant weight gain. You can see the green is those that have no significant increase or decrease in weight gain. The other interesting thing for men, if you look at the left graph, is that the weight gain seems to occur over the first year of treatment and then stabilises. This is quite different for women. You can see that there's a greater effect for women, with 35% experiencing greater than 20% weight gain in over 2 years, and that weight gain doesn't stabilise at 1 year. It continues to occur. Now, the advanced study was done in Africa, so these are Black women in the main, and so one can see this significantly greater weight gain. Now, if we move to liver function abnormalities, again, we have a spectrum of causes. We mustn't forget hepatitis co-infection, and this includes hepatitis A. We've had a hepatitis A outbreak in our cohort of men who have sex with men over the last 3 to 5 years. Recreational drugs and alcohol can also cause abnormalities in liver function tests. Herbal and traditional treatments can cause abnormal LFTs. Do not forget syphilis. Secondary syphilis without a rash can cause a hepatitis. And of course, underlying liver disease, whether that's due to hepatitis B, hepatitis C, and other causes, which we will explore more in the next module, and HIV drug-related abnormalities. So the spectrum of the clinical problem is that the changes are usually mild if associated with antiretroviral therapy initiation, and they're transient. If they continue, one needs to consider underlying liver disease as well as antiretroviral therapy. The minor changes can be common. I think they're less common today. They're more common with initiation of protease inhibitors and NNRTIs than with the integrase inhibitors. Severe hepatotoxicity and acute liver failure is extremely rare and occurred mainly with nevirapine and efavirenz. One must be careful, though, with rilpivirine. So what are the other causes? Remember syphilis, hepatitis A, hepatitis C, and hepatitis B, recreational drugs and alcohol, pre-existing liver abnormalities or liver disease, over-the-counter medication or prescribed medication. We're going to talk about non-alcoholic steatohepatitis and IRIS in the next talk. As always, we check liver function tests 2 to 4 weeks after initiation of antiretroviral therapy. Efavirenz, we rarely initiate today, but rilpivirine can be initiated, and they can cause some symptomatic or asymptomatic liver function tests. Fulminant hepatitis is rare, but it has been reported. Protease inhibitors, atazanavir, causes a raised unconjugated bilirubin with or without clinical jaundice. If it does cause clinical jaundice, it is worth changing the atazanavir. We have many other antiretrovirals to choose from. Darunavir is a rare cause of severe hepatitis. So what do we do when we have a change in liver function tests? We consider whether it's likely due to antiretrovirals. We look at the trend in the liver function test rise. We look at other liver function, for example, clotting and albumin. Does this individual actually have cirrhosis and chronic liver disease? Repeat the liver function tests until they stabilise. exclude concurrent causes, and only stop the treatment if the liver function test abnormality is persistent and persistently greater than 4 to 5 times the upper limit of normal, and always discuss with your mentor and hepatologist. Finally, gastrointestinal side effects, again, they're usually self-limiting, mild to moderate. Nausea and vomiting are much less common today, but can be seen with a number of antiretrovirals. Diarrhea is much more common with the protease inhibitors. It just doesn't seem to occur with the integrase inhibitors, and it's much less common with the contemporary protease inhibitors, with darunavir. It is common with lopinavir, less common with atazanavir. With diarrhea, again, don't forget symptomatic HIV, advanced immunodeficiency will cause diarrhea, and the treatment of that is antiretroviral therapy. If the CD4 cell count is less than 200, is there another opportunistic infection causing the abnormalities? Don't forget alcohol and diet. Concurrent infection, we have outbreaks of Shigella proctitis that is sexually transmitted. Always important to rule out concurrent infection with acute diarrhea, particularly acute bloody diarrhea. Underlying bowel disease is not uncommon in our patients with HIV. Don't forget Crohn's disease and inflammatory bowel disease, and then HIV drug-related causes. The spectrum can be transient, minor, not an issue, but it can become a long-term issue. Severe uncontrollable diarrhea is extremely rare with the modern regimens, and would be likely due to something else. So if you have a patient with diarrhea and recently commenced antiretroviral therapy, things to think about: is this antiretroviral related? How immune deficient is my patient? Could this be symptomatic HIV or other opportunistic infection or iris? Otherwise, think about other causes of diarrhea, inflammatory bowel disease. Is it diet related, alcohol related? Is there malabsorption or intercurrent infections such as Shigella? And I will stop there. If you have any questions, please submit them to the chat line.